It was easy. I thought there was just a button you click.
Yeah, I think we're live on YouTube right now.
Oh yeah, cool.
Yeah. Okay, I think we can start right now. Hey, Marco.
Okay, great. It was easy. I thought there was just a button you click.
Now.
Yeah, I think we're live on YouTube right now.
Oh yeah, cool.
Yeah.
Okay, that's okay. I think so. You can start.
Okay, I think we can start right now. Yeah.
Okay.
Pode começar, né? Libera então aí, todo mundo. Vou liberar o de tela aqui. Tá liberado.
Liberado?
Na tela. Robert, you share your screen?
Is that how you want to do it? Oh, I'm sorry. I thought you were going to play the recording. Oh, yeah. So should I play the MP3 recording?
No, just a recording on YouTube.
Oh, okay. I got you. I'm sorry. My mistake. I made that recording. I thought that we were going to play the video of the talk and then do it. But you want me to give the talk live?
Yeah.
Gotcha. Okay, my bad. So let me find the talk actually. Give me 1 second before we.
Okay, take your time.
Yeah. Okay.
Apresenta ele aí, Bruno. Vamos embora.
And which one was it? So tell me again, are we going to do lumbar disc herniations or lumbar athletes?
Lumbar athletes.
Yeah.
That's wavy. Robert, you can share your screen?
Yeah, I will. It's just it's downloading. It's getting the talk off the cloud. I don't know. My computer does that a lot, and it's kind of like annoying.
Is it a Brazilian computer?
Yeah, exactly. Hospital Wi-Fi. That's the problem.
Yeah, yeah.
All right. Here we go. Lumbar disc herniations. Let me do that. Now let me go back to Zoom, share screen. Okay, we good?
Yeah.
Okay, cool. Actually, let me do it this way. Okay, great. Okay, so this talk is on lumbar disc. Let me just make sure real quick.
No. It's not this time.
Yeah. Not this.
Not this?
Yeah, athletes.
Yeah, lumbar disc herniations in athletes?
Yeah.
The list is the athlete.
Yeah. This is it. This is all athletes. Okay, let me go back. Let me go back to the beginning. Yeah, I apologize. I thought we were going to play the recording that I had made before. So
No problem.
I'll just give it off this. All right. Lumbar disc herniations in athletes. And so I'm Robert Watkins, the fourth. As you mentioned, my dad earlier, he's the third. And we've worked together for 17 years. And my dad was the first spine surgeon taking care of athletes 30, 40 years ago and developed a rehab program, which is so key to avoiding surgery, because most athletes don't need surgery, but then also after your surgery, how to protect your surgery to get people to return safely without messing up your surgery. And so the rehab is the key. And we have an app called Back Doctor, has the whole program in it. It's free. You can get it at the App Store. But I'll go over how we treat disc herniations in athletes, when to do surgery, when to not, and what are some of the complexities. And so currently I take care of the Rams football team, Dodgers baseball, the Clippers, Lakers, the Kings hockey, soccer, LAFC, and we also take care of all the USC athletes. So spine surgery in athletes, the summary is basically if you're operating on nerve pain with mechanical irritation of the nerve and there's a mass on the nerve, it has a 90% success rate, as compared to if you're operating on an injured disc that's causing referred pain without mechanical nerve irritability, and you're doing the surgery because the non-operative program's not making progress, well, the results of surgery are more like 50-50. It's not nearly as likely to work. And so, there's my summary of taking care of athletes. And sometimes we're kind of forced to do that because you're taking care of an athlete, they struggle to make it through the year, they're still having some pain at the end of the year, but they're doing okay. And you don't know, well, should we do the surgery now so that you can get better for the next year? Or if you stop playing in rehab, are you going to get better and not have to have surgery? And so they're tough decisions. There's no easy answer, but I'll try and take you through how we make that decision. So as a spine surgeon, obviously be the patient's objective advocate. You got to determine the risks of playing with or without surgery, communicate the same message to everybody. After every time I see a player, I try and talk to the family, the agent, the trainer, the team, try and talk to everybody in front of the players so they hear the same message, everybody's on the same page. Don't do anybody too much of a favor. We know how that is. Just stick to the medical facts and do the right thing. Don't forget, you got to take care of the patient. That's your job. So you got to get well first. Don't play if you're hurt, and put the rehab first. So you conquer the fear through the rehab and conditioning. And so the athlete proves that he or she can play. On the physical exam, the pertinent things we look for: single leg extension, make sure they don't have a stress fracture. Faber test, make sure it's not a hip issue. We've also picked up stress fractures in the hips. So you got to be very diligent about these early 20-year-old athletes. They get stress fractures in the hip, the back, everywhere. You got a high level of index of suspicion. And then one of the big things on the physical exam is really checking the strength of their hip abductor. If they've got an L5 radiculopathy, they'll get weakness to their hip abductor. And a lot of times people don't really check that. And if the EHLs may be weak on both sides, anterior tib may be strong, but the hip abductor, a lot of throwing athletes, hockey players, soccer players who balance on one leg, it'll throw off their mechanics. And it also determines an L5 radiculopathy versus perineal nerve or peripheral nerve issues, that hip abductor. I'll skip some of the easy stuff. As far as the nerve irritability, the most sensitive test for us is the sitting slump test. Sit up straight, straighten the leg, flex your neck down, and do they have nerve irritability? Can be the most sensitive, but can also be indicative of just a disc injury, not necessarily nerve compression. The most specific is the popliteal cram test, is sticking your finger in the popliteal fossa, extending the knee while you're pushing on the popliteal nerve. If that reproduces their leg pain, it's the most specific that surgery may help them. And then the other components. Diagnostic studies. This CT SPECT scan is the best test, where they merge a SPECT bone scan onto the CT scan. You can see the metabolic activity. The patient can see it. It can show them what the problem is if they have a stress fracture. But then obviously MRIs. So if somebody has an acute herniation, we treat them with anti-inflammatory, steroid pack. Epidurals we do for pain. We don't do epidurals for weakness. So if they have a painless weakness, with no pain, we typically don't do an epidural. We do it for pain. Do the trunk stabilization program. As far as returning to sports with a disc herniation, you have to estimate how long till they can make it back. It's extremely difficult because we don't know. It's going to be between 1 week and 6 months. So what do you say? You say 6 weeks. Let's start with 6 weeks and reevaluate. And here's just an example of a Major League Baseball player, had severe pain, radiculitis, truncal shift. I mean, he was bad, really tight, shifted over, positive straight leg raise. I did an epidural on him, and he had this annular tear, small herniation, but pretty well contained. And it was displacing his S1 nerve on the left, and with a positive, nerve tension. I did an epidural, pain went away pretty quickly. He actually played 2 weeks after this, but it was also playoffs, big time game that he needed to play, and he could play, and he played effectively. Other side of the example is another baseball player who had this herniation. You can see on the right picture that it was more of a distinct herniation, but on the axial pictures was not touching the nerve as much. And this guy took 5 months to make it back to play because of his contract. He didn't really have much of an incentive to come back. So my point is 2 weeks or 5 months, the MRIs don't look that different. It's hard to really know which way they're going to go. And again, guy on the left, 2 weeks, guy on the right, 5 months, don't look a whole lot different. So what are our guidelines? We basically start with plan on being out of the sport for 6 weeks. Everybody can relax, see how it goes. Worst prognosis is bigger herniation with nerve compression, neurologic deficit with weakness, obviously, severe pain, real nerve irritability. And if they don't respond to the steroids or to an epidural, more likely to need surgery. Non-operative return is not much data on it, but it's showing around a 90 to 95% return. The average non-operative return was 3 to 4 months, which is a great number to know, because what's the surgical return? 3 to 5 months. Well, non-operative is about the same, and I'll get into some more specifics about that. How do we treat them non-operatively? Don't do anything really the first week. Level 2, we start neutral core stabilization, walking, and then work your way up, get to level 2 of the program. See, it's 5 levels of strengthening. As you get to the higher levels, you can do more physical activity. When you get to level 2, you can do non-impact cardio, elliptical, bike, start to jog with 50% of body weight, shoulder exercises. Level 3 is when they can do sport-specific exercises, 4 practice with a team, 5 before they go back to play. So when do we operate on them? All the usual stuff. How bad are the symptoms? Size of the fragment, underlying congenital stenosis, make sure they don't have a stress fracture, and depends on when they are in the season whether we're going to recommend surgery or not. The 2 different types of surgeries we do, if it's a classic posterior lateral herniation, we use a McCullough blade and spike retractor, microscopic discectomy with a laminotomy, take the fragment out. If it's a far lateral herniation hitting the exiting nerve in the foramen, that's when we use a tube, because we can come in at about a 30-degree angle and come, outside of the facet and preserve more of the facet joint. Take out the tube take out the disc through the tube and the microscope. And so pretty standard surgeries. We do not use a tube for the midline surgeries because we don't think it makes a difference, and it kind of can restrict your motion. Whereas for the far laterals, it does a good job of staying in place, lock it in place, get the angle you want, and it prevents muscle from creeping in. And then, you take the tube out and the hole in the muscle closes back down, which is of benefit too. Return to play after discectomies. We start our rehab program usually 4 weeks after the surgery. Return to play is generally 3 to 6 months. You got to complete the rehab program, got to be in good aerobic conditioning, sport-specific exercises, be at a high enough level of skill that your team can depend on you, and then continue the program once you go back. Our results of discectomies, we reported 85 pro athletes. Return to sport was 89%. Average return was 5.8 months. So return in 5.8 months, but a lot of that depends on when they're in season. Football players have an 8-month off season, so they might not have returned for 8 months, but they could have been ready earlier. So we also looked at if their sport was in season 3 months after the surgery, what was the chance they played in a game 3 months post-op, and it was 50%. So actually half make it back and play at 3 months. But a lot of the athletes I've operated on who have played at 3 months say that it takes about 3 months of playing in addition to that to they really feel normal. So the return is probably really 6 months before they feel normal, which is, I think, most people's experience. what are some of the general population results? What's the point of this is just basically surgery gets a bad reputation, when in reality, discectomy is a great surgery, even the general population. Follow up to 6 years, still having an almost 80% success rate. And same, the sport data showed up to 8 years, good results. Does the surgery lead to future problems? Recurrent herniations between 10 to 20%. But the incidence of recurrent pain in the non-operative patients is pretty significant, not that much higher than the operative patients. So surgery does not make you worse long-term. What's the risk of needing a fusion? It's about the same with or without. If you have a discectomy, it's about 5% either way. So the answer is surgery doesn't make long-term prognosis worse. Laser spine surgery, I'll mention this, the Laser Spine Institute in America did $1 million a month of advertising. It was all over the place. It was a big hit 3 to 4 years ago. They basically were just doing a tubular discectomy, saying they used a laser, and it was basically just marketing BS. They didn't do as well, but they weren't very good surgeons either. Endoscopic, I think, has really promising potential. But the key is, with any minimally invasive technique, you've got to safely protect the nerve, right? That's the key. Don't hurt the nerve. You got to be able to see the nerve. And also, technically, can you mobilize the nerve safely? For us, we generally have my 2 surgeons, especially for the athletes, under a microscope, which kind of gives you 3 hands. One person can gently retract the nerve. The other one can suck and do other work, and you get different angles. Where we really barely move the nerve and can adequately take everything out. So if you're doing it with an endoscope and you're using the portal as your retractor, well, that's not as good as a hand that can really monitor how much they're doing. But because it's so small, it can still be okay and maybe even better. But you gotta make sure you know exactly how much tension you're putting on the nerve and how to evaluate that. So you got to safely protect the nerve. Get rid of the pathology. Also with the endoscope, if you're going, midline, how much of a laminotomy, ligament and flavum removal are you doing, which may prevent symptoms if they get a bulge down the road. And then obviously save the facet joint. I can't tell you how many decompressions I've seen with a tube where they take out too much joint, because I think they come too lateral, they get a little disoriented. You got to save the facet joint. Obviously, that's the key. And then decrease the chance of recurrent symptoms. And this is just an example of a case that came to me. This was done by a surgeon who advertises minimally invasive center and has a pretty good reputation. And this is the same cut, one cut down. The picture on the left, you can see he did like a lateral foraminal approach. But if you look at the picture on the right, the stenosis is still there. And so, this is a different case. This is more older person with central stenosis. But it looks like he took out too much joint and did not treat the central stenosis, which is not ideal. So here's some cases. Here's an NBA power forward, 3-day history of right S1, pain and weakness, unable to get up on his heel. So he had a weak calf, an NBA player with a disc herniation. And so should you operate? And sometimes we have operated on these, but it was only 3 days. So I did an epidural. I do an S1 nerve root block and a transforaminal. I always do 2 shots at one time. Just get above and below the nerve and flood it. And his pain went away immediately. So now he's got no pain. So now I just watched it. Every week I examined him. Strength got better. Did not need surgery. Went back to play with no surgery. It took him 3 months to make it back to play. But, you don't always have to operate on him. Here's another non-operative case of an NFL player with a big herniation in L5-S1. But, there was more room for the nerve down there and able to treat him without surgery. These football players are tough, man. They don't feel pain like the rest of us. And a lot of times they can get by without having surgery. Here's another example of another NFL player, played for 15 weeks with this disc herniation pushing on his S1 nerve. Then he developed calf weakness, and the herniation had gotten bigger, more of an extruded piece. Did the surgery in that case. Another NBA forward, disc herniation, L5-S1. The picture on the bottom right axial cut, pushing on his S1 nerve. Did an epidural. A week later, gets a bigger herniation, extrudes the fragment, develops weakness. Took him to surgery, did the surgery, took out the fragment, returned to play 3.5 months after the surgery. but he was one who said he was back playing, but it took him 2 to 3 months of really getting in shape playing to where he felt like he was whole. So I tell people it's like a 4 to 5 month recovery. Here's a case of a 25-year-old baseball infielder, had a right L5 radiculopathy with anterior tibialis weakness. He had a foot drop, 6 millimeter spondylolisthesis that increased to 8 millimeters on the flexion view, with a herniation in the frame and at L5S1 hitting his L5 nerve, which typically we'd say fuse it. We do an anterior posterior fusion, no problem. But on his MRI, you could see the herniation on that axial cut was pretty medial, to where I thought with the microscope we could come in and do a laminotomy. The key in doing the laminotomy in this case is don't get into the pars defect and destabilize the fibrous tissue around the pars defect. And so, but we really worked at an angle from caudal to cephalad, undercut it, and took out the herniation with the microscope and no fusion. And he went back and played 3.5 months after the surgery. What about doing fusions in athletes? There's only really been one report in hockey players, and it reported that 8 out of 8, 100% returned to play. And they returned for a good amount, played for 4 years after, and there was no real difference before the surgery versus after the surgery in performance. And so fusions in hockey players has been shown to be successful. We rarely do fusions in pro athletes because obviously they miss a whole year, and what's the chance of them going to come back and change the biomechanics? We've done about 3 in 15 years, so very rarely. And there's a difference between a 25-year-old who misses a whole season and tries to go back to professional sport. The chance of them making it back to be able to play is not very good, maybe 50-50 at best, as compared to a 17, 18-year-old with a spondylolisthesis that you fuse. Their chance of being able to make it in their future, in their 20s as a pro, is much better because they still have time to adapt and to recover. And doing a fusion for a spondylolisthesis has a better success rate than like a degenerated disc, which we all know that. And there has been football players in the NFL who have played with fusions after spondylolisthesis. Here's an example of a pitcher we did, 34 years old, a year and a half of back pain, degeneration of his L5S1 disc, and we did a fusion. And the CT showed bridging bone. I thought he was fused, but he was still symptomatic, and basically he just never made it back. And an artificial disc replacement is a viable option in athletes. We are very limited in artificial discs in the lumbar spine, because we tend to try and treat those people non-operatively and do our rehab. And we've seen complications with lumbar artificial discs. Revision surgery is very difficult. We've had a couple patients that we could not go back in and take the device out from the front because the vessels were scarred down. We tried to fuse them posteriorly, got non-unions because of the motion through the artificial disc. So we do a lot of cervical artificial discs, great surgery. Lumbar, I still do, but very rarely. I typically will do, like if they have a spondylolisthesis at L5S1 and a degenerated disc at L4, L5, I'll fuse L5S1 and I'll do an artificial disc at L4, L5. And I've done probably 3 of those in the past year and a half, and they work. But we're more limited in the artificial disc and the lumbar spine for those reasons. Even though I'd say half of our patients with lumbar artificial disc do great, maybe even 70%, but 10% still struggle. They can always dislodge, they can come out the front. As far as artificial disc replacements in athletes, Mayer, in Europe reported some success in athletic type of people, but most of them were not athletes. They were just kind of recreational athletes. He had one pro soccer player, he said, made it back to play, but he also had one pro golfer, one pro wrestler that didn't go back for unrelated issues. And he had a karate instructor who couldn't compete due to the pain with rotation, which they thought was probably facet joint pain. So not much data on artificial discs in athletes in the lumbar spine. As I mentioned at the beginning, the toughest cases, you got a lumbar disc herniation without significant radiculopathy, no real nerve irritability on the exam, struggle to finish the year. The season's going to start in 3 to 6 months. What are you going to do? And basically, your number one choice is give them time to rest and rehab non-operatively. But there's a risk they won't be ready for the next year. They may miss the whole next year if they have to have surgery. Or do you do a microdiscectomy if they've got any type of nerve pain or nerve irritability, or do you jump right into the fusion of the artificial disc? We almost always do the first, unless they've got some real nerve compression that we think it's mechanical nerve pain. Then we'll do the microdiscectomy. We almost never do the last option. Returning to sport, you got to be able to control the rehab. And our program, if you don't have a non-operative program and a plan, well, then how can you give proper advice whether they should have surgery or not? You don't have an alternative treatment. So you got to have a rehab program, especially if you want to take care of the athletes. We manage them from the day they get back pain. I manage, 95% never need surgery. Well, I still manage it. And you kind of got to get in there and do it. And also the rehab will protect your surgery. Here's my dad a long time ago, establish a neutral pain-free position, balance and coordination, breathing and endurance. Green ball, everything else, 5 different levels. And that's how we let people go back, because and then we treat everybody with this. 70-year-old guy, we do a discectomy. When can I play golf? Well, get to level 3, then you can play golf. It helps for everybody. Everybody's on the same page. 7 different exercises, got the levels. The 2 bottom components, aerobic and sports, says, okay, when you've obtained level 2, you can do these physical sporting exercises. And it's all on there. It's on our app. It's free in the App Store. It's not in Portuguese, but soon. That's Marcos's job. There's my email. Thank you very much. And can I take any questions?
Right. Congrats, Robert. I think this is a big challenge. This kind of patients is a big challenge to treat, right? Because this is not a let me say, common patient. Sometimes they are worldwide famous, so it's a thin line to do it success or not. So it's a big challenge to do it. So Fogassa and Marco, could you tell us something?
Well, thank you very much, Dr. Robert, for your talk. Very good talk. And I would ask you, do you do your own blocks foraminal epidural, or you ask for a CT guided or another one to do them?
I do them myself. So I actually trained in England for 1 year. I did my fellowship in England with John Webb and Mike Grevitt and Nottingham at the Queen's Medical Center. And part of my job as a fellow was to do all the injections at the end of the day. All the surgeons went home and the fellows had to do the injections. So then I came back into practice and I just kept doing them. And so it's been very helpful for taking care of athletes, because say, the Dodgers or one of the local teams, somebody gets hurt, they come to see me, I do an MRI, an exam, everything, and then I'll do an epidural the same day. So within an hour and a half, they get an exam, a diagnosis, and an epidural, start the treatment right away. And so it's extremely helpful. And also I'm doing it, so I know exactly what I want to do. Sometimes the pain management doctors just do one injection. And for me, it's like, I know my objective. If it's for diagnosis, I may just do one nerve root block. And I get feedback when I do the injection. I ask them, does this reproduce your pain? Is it the same pain you usually have? And then I do the injection. But for most of the athletes, it's not about diagnosis. It's about treatment. And so I will sometimes I'll do 3 or 4 epidurals. I'll do both sides. I do whatever it takes to give any pain relief. And so that's one of the benefits of doing them myself, is that I either am more diagnostic or I'm more aggressive and I just flood everything I can. Plus they're young, healthy guys, right? They're 22 years old. And so I'm not that worried about doing 4 shots. Their body can handle steroids. So I do them myself. I do not do rhizotomy or radiofrequency ablations, but that's, really for facet pain, which is extremely rare. But I do the injections, and I do not do cervical epidurals. I just do lumbar and thoracic.
Okay, thank you.
Yeah. Hi, Rob. Thank you.
Hey, you bet.
How are you? Thank you for being here again with us. My question is still on these blocks, you say you do. Did you see sometimes when you have had to operate these guys that you made the foraminal blocks before? Were there any changes inside the canal because of the asteroids? They can make some changes inside the canal and near the disc herniation.
You know, I can see the steroid, the particulate matter on the dura, but that's it. But that's it. I don't see like adhesions or pathology that of any significance. But, you know, to be honest with you, it's kind of a pat on the back when I do the surgery and I see the steroid all over the nerve and I say, hey, whoever did this shot knows what they were doing. I say that when I did the shot, especially but you know, but you know, and you know what I mean? You see that kind of coating where we think, well, but I've never seen that to be an issue.
I don't make it more difficult, the surgery.
No, it does not make it more difficult. Not in my experience. I don't think there's more adhesions or scar tissue or anything else. Yeah, it's just but you see it. It almost, I mean, it shows you the dura, you know, you're like, oh, there's the nerve because the steroid will be on top of the dura.
Okay.
But I don't think it's adverse. I don't think it's a negative.
Okay. I have another question. We talked about this before, but I know you like the microscope.
Yeah.
And the endoscope is being used more actually, particularly in the L5S1 interlaminar approach. It's easy and fast. And I saw another day you were like training this. You put in
right.
You are training some endoscope too.
Yeah.
Are you up with it?
So not yet. Our hospital has not purchased it, you know, and COVID didn't help with any of the, you know, new technology. But I still am planning on, I'm planning on moving to the endoscope because I do think the technology is better. Like I said, you know, and right now for me, especially for the far lateral herniations, the foraminal herniations, I would use an endoscope tomorrow. Because right now I already use a tube and a microscope and I do so many transforaminal epidurals that coming in through the foramen to do that, you know, I look forward to using an endoscope because I can see. I would like to be able to see closer and see different angles under the nerve, the benefit of the endoscope, which you don't get with the microscope. And so, you know, I think I'm not sure yet, and I'll be interested. You tell me your experience as far. I do think there's some interesting history that, like, I know, you know, some other surgeons. I won't mention them by name, but because, like, I know a surgeon who has a lot of experience with the endoscope, and more than, you know, probably top in America, one of the top, you know, in America, and he said he only does like 25% of his lumbar decompressions and discectomies with an endoscope. And 75% he still uses the microscope, which is interesting, right? Because it's one of those things, you know, those curves of some new product comes out. It's like lumbar disc herniations. I did a lot more 15 years ago, but we don't do as many now. And so you never know, is this something that's gonna, or how many recurrent episodes do you have? You do an endoscopic surgery and somebody has recurrent pain or recurrent herniation, you didn't relieve the stenosis. You know, how many of those do you do and how much do you blame on the endoscope, or is it just the natural history and it would have happened with the microscope too, you know? And so I think that it is part of the future. I think the technology is much better. I think the instrumentation is much better. I think that when it becomes navigation compatible, and I looked at JoyMax and I was really interested in because I use the O-arm navigation for every screw I put in, including stress fractures in athletes, percutaneous, you know, lag screws. It's really cool. It's not easy because the instrumentation is not made for it, but the cases we've done have been really cool. So my point is, you know, if you can use navigation with the endoscope, I mean, I think that's the future. It's not there now, but in 5 years, I think it will be. And so I think when all that merges together, I think it'll be even more utilitarian. I hate the idea of having to wear lead and shoot fluoro for my decompressions. I mean, I need to, and so right now you gotta wear lead, you gotta take a fluoro and take fluoros to do a discectomy with an endoscope now. At least people that I know in America are using that. So I do think it's the future. I think it's got a lot of promising potential. I think it still comes down to, are you doing a laminotomy? Are you removing the ligament of flavum? Are you doing a medial facetectomy? Do you need to or not? And you got to be able to safely retract the nerve. That was the one thing there's a couple technical points. I'm not very happy about retracting the nerve with the trocar. Like, I realize you could get good at that, but you know how it is. I mean, there's cases where like the dura's stuck and you're not going to know that. If you use an endoscope, you're just going to either tear the dura. Maybe it won't matter because your incision's so small. Maybe it'll push it away.
You have a high rate of dura tears in the interlaminar approach with this trocar you're saying. When you turn it on to see the root, then you'll make the lesion on the dura if you don't have enough space.
Which you know how it is right now. Right now, it's like I do my laminotomy, I pick up the lateral part of the nerve, and you can tell if there's a disc herniation pushing the nerve lateral. Well, you're much more gentle, and you go higher, and you go up into the shoulder of the nerve, and you mobilize, and you start to work, take out some disc, and then mobilize the nerve. And we have a great feel for how tense is the nerve, how much can we move it and take out the disc. And with the endoscope, it's, I realize with the endoscope, you can break the adhesions, break the ligamentous adhesions first, do some mobilization before you do the trocar move. But getting a sense as to how tight are things, how safe are you to do that move, it's not going to be as good as with the microscope, where you have that tactile feel and you can see it. But is it worth the less invasiveness? Well, it may be, so I still plan on getting my hospital to provide us with the latest and greatest technology. And I really do think the endoscope is part of the future. And I think surgeons who do a lot of them, can do it safely and do it well. And then it comes down to how much of an advantage is it? Do I think that what we do to the muscles now prevents athletes from returning to sports? So, 10 to 20% of athletes will struggle or not make it back to their sport. Do I think it's due to the muscular approach that we do now? I don't think it is. I think it's due to the disc and to the nerve, and mainly the disc. Whether athletes go back or not, it depends on, do they have disc pain? Can they handle the axial loading and weightlifting and running and impact of their sport? That's based on the disc. It's not based on our muscle approach. So I'm not really in dire need of a less invasive technology for treating the athletes with disc herniations now, because I don't think that's a fundamental problem. It's the quality of the disc, I think, really, and discogenic pain is what determines some of the athletes who don't make it back to their sport.
Yeah, I think you're right.
Yeah.
There is a question for you from Mendel Sapanuru. What would you do if your physiotherapy support is not so good? You would go direct to surgery sometimes?
Hopefully not. It depends on how many surgeries you want to do. So it's tough though. I do see patients from all over the place, and you can't always control the rehab. And that's part of why we developed our app, is so that it's systematic, same program, everybody do the program. And so I ask patients, I say, they come back and I say, so what level are you doing? They say, can I throw yet? What level are you doing of the program? If they say, I don't know, can you ask the therapist? I say, that's not good enough. You need to know. The athlete, the patient needs to buy in. They have to own it. They got to tell me what level they're doing. If they don't know the level, then I'm not happy. I tell them that you got to own this. And so one of the benefits of our program is just standardization of people can go to any physical therapist and learn the program and do it. But, but you're right. Some of the physical therapists, you don't want them to hurt patients. You don't want them to manipulate them too much, not too much crazy stuff. Just do the exercises, get their muscles strong.
Maybe this back pain makes you a great surgeon.
Yeah.
Because it's easy. All your patients are going to be good because of the rehab too.
Right. Yeah. It helps. It
Your
helps.
good
You got,
results.
and you're right. One of the hard parts about doing a discectomy, Bruno mentioned, some of these athletes, and some surgeons, quite frankly, will tell patients, "Oh, we'll do a discectomy. You'll be back to play in 6 weeks." And so that's part of your competition is, I'm telling them our average return is 5 months. Somebody else tells them 6 weeks. They just think the other surgeon's better, and so and the athletes think if you tell an athlete they'll be back in 3 months, they think I am twice as good as everybody else. So I'm going to be back in half the time, and so it's hard. So you got to convince them. And that's why the program takes that out of it. We try not to use time. We try and say levels of back strengthening. Get to level 5 and then we'll talk. So yeah, I think it helps. It helps everybody get away from the time and more focused on the rehab and doing the work.
Sure.
I think this last question is not your case, because here in Brazil we have from health companies a therapist is very bad. So this is not your case, because 15 years ago you saw you have a good and great team, all the staff, nurses and physiotherapists and physicians. So I think this is not your case, right?
Well, no, that's not necessarily true. Like in our facility, we do not have physiotherapists. So I don't employ any. I have no, so all of the physiotherapists I use are private practice physiotherapists all over Los Angeles, California, everywhere. So I rely on relationships with physiotherapists who will do the program. And sometimes it's difficult because they think and sometimes are a better expert at physiotherapy than I am. That's not my forte. And so they think they know what to do. And some do, some of them I trust, and obviously they can tailor it to each individual person. And our program is very generic, which a good physiotherapist it's appropriate to change it and to tailor it. But at the same time, if they want referrals from me, the patient's got to do the program, because I need to know what level they're doing. And some physiotherapists fight that a little bit. They think our program is too static, too ground-based, and they think it should be more dynamic and more standing and more upright. And I respect that, but at the same time, that's the transition. Start with our program on the ground, get your core strong, then move to more transverse plane and rotation and standing exercises. But it's a good place to start to help protect your surgery. If your patients are at a level 3 of our program, they can go back and do Pilates and yoga and other things pretty safely, but they got to get to level 3.
So do you use that strap table, that's a decompressive table, like spine med?
Yeah. Do we use a decompressive table?
Yeah.
I don't. My take on chiropractors, decompressive tables, traction, acupuncture, epidurals, massage, dry needling, it's all the same. If you've got a good practitioner and they know what they're doing, and if it works and it helps the person 1 or 2 times, keep doing it. All those are the same. But then once you relax the muscles, then do the core program, then do the strengthening exercises, and that's where it's standardized. That's where I care what they're doing. But the first part, whatever works, I'm fine with. I mean, in America, a lot of chiropractors and other people will say you got to do a decompressive machine 3 days a week for 6 months and charge them a lot of money. Well, that's obviously crazy,
Right.
And so we have to fight that a little bit. But at the same time, I think, the theory of decompressing the spine to relax, then do some exercising, I'm okay with. But let me say one other thing. I do not think it fixes disc herniations. It does not reduce disc herniations. Yeah, right.
Robert,
Yes.
when you do total disc arthroplasty,
Yes. When do I do?
Arthroplasty.
So for cervical spine disc herniations and problems, I do about 70. I'll do lumbar. I do about 75% disc, artificial discs, 25% fusions. So I do mainly artificial in the neck. Lumbar spine, in the past year, I've done 3. When somebody had a spondylolisthesis of L5S1, I did a fusion of L5S1, and L4-5 had moderately degenerated disc that I thought was contributing to the back pain. I did an artificial disc at L4-L5 with the fusion of L5S1, a hybrid. I think actually I'm doing a lumbar artificial disc coming up in a young man with a relatively flat L5S1. It's not very sloped, relatively flat, degenerated disc. He's had it for 3 years. The other discs look normal, no nerve pain, no foraminal stenosis, pure discogenic pain. Facet joints normal, and I'm going to do an artificial disc in him. Where, whether to fuse it or do an artificial disc in that case, I don't think makes a whole lot of difference. But because he is such a perfect case for discogenic pain, I'm going to do an artificial disc in his case. And my patients that I've done artificial discs in have actually done really well. I can't remember anybody that I personally did that I've had a problem with, but I've seen enough in the community struggle, and they're so difficult to know what's causing the pain after a lumbar artificial disc and what to do about it. Like, there's no way to really know, should I fuse this or not? And I don't like that gray zone. I'm a very black and white type of thinker. I like to know, what's the plan? Fusion, is it fused or not? And with an artificial disc, it's difficult. It's challenging to know. The 80% do great. Well, what about the 10% who don't? It's such a struggle that I try not to go down that path, even though it's still a good surgery. What about you guys? What's your experience with lumbar artificial discs?
Here was artificial disc work on 10 years ago, and is back in last year. It's back in to the country. So in the good patients with good facets, I think in young patients, I think is a good technique in my experience. Yeah. So there's a question here. Do you always use microscope or eventually use loops?
For what type of surgery?
He didn't say.
So I use both. So for like A lifts and laterals, X lifts, I use loops, 3.5 loops. For my approaches to the neck, I use loops and a headlight, loops and a headlight. Pretty much everything else, I use a microscope. So once I make the approach, I take off my loops and use a microscope for the discectomy and the implant. Because I like the angle of the loops. Using a microscope for the necks, I just don't like it. I like the loops. It only takes, it takes a minute. Take off my loops, re-scrub, and then for the lumbar spine, all my decompressions, I use a microscope. And then for the screws, the pedicle screws, I use the O-arm, and I put in almost all my screws percutaneous, so I don't wear anything. I just look at the computer screen, tells me where to go.
So orthopedics use microscope. Me and Marco, we are new surgeons, and we use it in 100% loops.
I do? Nice. That's funny.
Yeah, we don't use microscope.
Man, I love the microscope. Part of it too is that I work with my father and Dr. Chang, who's a spine surgeon, and the 3 of us and our PA, our assistant, has been with us for 13 years. So we have 4 doctors, 3 surgeons, and we have 2 surgeons on most cases. So the microscope allows us both to see the same thing and not bump heads, and we can both work at the same time. And so the microscope is good for no head trauma too.
Fogaça.
No more questions. Thank you.
You bet.
Can I make one more question?
Yeah, you bet.
Hey, Rob. Talking about this artificial disc again.
Yeah.
I don't see any reason to believe that there is a discogenic pain at all. I mean, the indications for arthroplasty, what are them? This is the gray zone you were talking about. I mean, if you have just a lumbar pain, low back pain, probably it's coming from the facets and not from the disc. What do you think about this?
So I think there's a difference between, is discogenic pain real versus can you diagnose it? Those are two different issues.
Okay.
Is discogenic pain real? Yes, no question. The discs are richly innervated. The discs cause most of the back pain.
Okay.
So yes, it exists. Now, the second question of, can you diagnose it accurately? And can you know which disc is causing the discogenic pain? That's very difficult. And that's why I am very conservative about doing artificial disc replacements, is because of the diagnosis. And after the surgery, if somebody's still having pain, what's causing the pain? What's the diagnosis after the surgery is very challenging. So there's a difference between what's the accuracy of your diagnosis, which is worth hesitating doing artificial discs, versus does discogenic pain exist?
Okay.
Because I think there's no question it exists, and it can be disabling. And the proof is patients I've had with discogenic pain that I have done artificial discs in do great, and they love you for doing it. You give them their life back. And so, but you know, so it kind of answers both, where it's like, no, it exists, but the difficulty in making the diagnosis is why we need to be very hesitant about doing the surgery. That's why we try and treat them non-operatively. But you know, like this patient I'm going to do coming up, or other patients in the past, you know, you have people in back pain for 3 years, 35 years old, 3 years of disabling back pain with one disc that looks terrible, and everything else is normal. I mean, 3 years, it's like, how much longer does this person have to suffer, you know? And I think that's a good reason to do the artificial disc in that type of case.
Okay. Yes. I
Let me
agree.
ask you a last question. You said in your talk about the LSI, the Laser Spine Institute.
Yeah.
That guy are gone?
Are they gone?
Yeah.
Yes, they went bankrupt. So they got sued by multiple people that had complications, and they went bankrupt, and so they're gone. So we never have to watch the advertisement on Sports Center anymore, because they were all over the place.
So we talked to Dr. Zawari from Celebration, and Dr. Zawari said us that he operated all patients that was operated on an LSI.
Right, exactly. I operated on probably 5. And one of the main complications was they took too much facet joint, because they were using a tube and they were too lateral and disoriented and took off too much joint. So, you know, and that's obviously the concern with an endoscope, not the same, but similar type of thing. You got to know where you are, you know, and you got to, you know, take off just what you need and leave everything else alone, save the facet joint, but still decompress the nerve. Marcos, one other thing about diagnosing discogenic pain, we also typically get a SPECT scan, bone scan, that CT SPECT scan. And if the facet joints light up hot, I will not do an artificial disc. So it's, you know, it's another diagnostic tool. And sometimes we may do a facet joint injection, you know, those types of things because in my experience, facet joint pain is not that significant. For me, 80% is disc pain, and that's where the mechanical loading and everything occurs in the lumbar spine. But the bone scan helps us a bit with that.
Okay.
So do you use some interdiscal therapy for discogenic pain?
No.
Don't you believe in this?
No, I do not believe in intradiscal therapy as of now. The IDET procedure, when I trained in England, one of my professors was Brian Freeman, who did a beautiful randomized controlled prospective study and showed the IDET did not work. And for me, it obviously makes sense. Like, can you burn human tissue and make it better? No, you burn tissue enough to where you're going to do something, it's not better. And so it's kind of, and then as far as stem cell injections into the disc space, I think that stem cell injections in the disc are part of the future. My estimation is 10 years from today, maybe 5, because you know how it is. It's such a harsh environment, acidic, hypoxic, avascular. You have a nucleus, you have an annulus. Which one are you healing? Are you going to heal both? The technology, the science and the technology behind stem cell injections is changing every month, which is not very reassuring, and so it's still very much the tip of the iceberg. I would not let anybody stick a needle in my disc and inject some blood product, stem cell, embryo, whatever into my disc. No way I'd let them do that, because I think it has a higher chance of causing harm than any long-term treatment. Maybe it would help for 3 to 6 months. Is it going to regenerate the disc and make it healthy for 5-year outcome? Highly unlikely, at least at this point, maybe in 10 years.
Right. Perfect. So does anybody want to, some question? Marco?
No question.
Well, I think it was enough. It was great.
Thank you.
Thank you. Join us. And apologize for the last week.
No, it's my fault too. I should have thought about it too. I apologize. I was all ready at 5 and then I got your email, but I'm glad we could do it again. And if there's any other topics or anything you guys would like to hear about, if I could help, feel free to reach out to me. It was a lot of fun. We'll have to meet more often this way and then in person, obviously, as soon as we can. It'd be great.
Sure. We waited. Okay, Robert. Thank you so much.
You're welcome. Thank you. Bye.
Have a good night.
Good night.
Thank you.
Bye. You're welcome.